right, ladies and gentlemen, now comes the moment that whereby we're going to invite our third plenary speaker to share with us about the study on mental health of migrant workers. Well, she has many, many hats on her. She's the founder of Insights Bridge Consultancy, adjunct assistant professor at NUS Yongloo Lin School of Medicine, and of course also Yale NUS College and director for the Center for Evidence and Implementation. So please join me and put your hands together to welcome on stage Professor Jean Liu.
Hi everyone, it gives me great pleasure to be here. Thank you for inviting me to this very important conference. I'm here to talk about bridging the gap, addressing the mental health needs of migrant workers. And primarily I want to talk about a study that I conducted during the pandemic. But it's been a couple of years and I'll try my best to kind of draw out some insights that last beyond the pandemic. I'll be very honest and tell you that when I was invited for this conference, the first thing I thought of was, but I'm not really a migrant worker researcher. I'm actually an accidental researcher in this field. And I'll tell you the reason. Usually, my area of research looks at how technology impacts health outcomes. But I'm an accidental researcher because, just now you saw the timeline of health serve clinics. Oops, how do I move the slides? Oh, there you go. When I first married my husband, he's an anesthetist, all our dates was him as a young medical officer going to health serve to the Jalan Besar clinic, if some of you remember that. And he was inside the clinic, and I was outside being his scribe. And I remember those early days when he would tell me, we're just going for half an hour. And 3 hours later, we were still there because the queues were very, very long. That was how we spent the early years of our marriage. And so a couple of years later, when I became the resident faculty at Yale NUS College, it was March 2020. Oops, where should I point in order to get this? Let me just point. Here? Point here? Yeah, okay, there you go. Oh, hang on. So in March 2020, what happened was I was resident faculty and I could invite any guest to come and speak at the college. So there was a lot of interest amongst the students about healthcare and about healthcare for migrant workers. So we got Dr. Goh in to come to speak. And of course, as many of you know, Dr. Goh founded HealthServe. And it just happened that, we had a very long live. Okay? It takes a very long time. The event was held right at the top of Yale NUS College. And while waiting to send him out, so it was a very, very long lift right down, you go 20 floors down and stopping at every floor for the students, I asked Dr. Goh, so Dr. Goh, thank you so much for addressing our students. That was a very informative talk. We have a bunch of researchers here very keen to volunteer and help out. Is there any area of research that we can help you in? And Dr. Goh immediately said, we need a mental health survey. Can you do it? So immediately, without skipping a beat, everybody in the lift, all the students said, yes, Prof. Liu, we can do it, right? So I said, of course we can do it. And that was how we ended up doing this research. So that was March 2020, and as all of you know, within a few weeks, right after Dr. Goh came, just within the weeks, right? So you can see over there, March 30th, the first dormitory cluster of COVID-19 was discovered. Very quickly, April 14th, all dorms were shut down. At that point of time, we immediately went back to HealthServe again, and we said, remember how we promised you on the lift down that we'll be helping you to conduct this mental health survey? Let's do it. Very quickly, as you can see, is on the right, let me just recap all the events that happened. There was a lockdown of all dorms. And this was not just in Singapore. This is global trends of migration and clusters. So you see over here, in Thailand, there was the same situation of foreign workers having a very high incidence of COVID-19 clusters. In Malaysia, 13,000 top glove workers were under a lockdown as well. And same in the Gulf, that also happened. So this was a general trend worldwide of migrant workers coming under the very, very high risk of COVID-19 clusters. Of course, here in Singapore, as we've probably spoken many times today, we have 164 million people, 400,000 of which were male workers employed in and largely in construction, shipping, and largely in dorms. At the same time, so disease prevalence 188 times higher than in the community at that point of time. And you can see all the different press coverage at that time. I'm trying to look at my slides and looking at this. Let me see what my slides on here. Okay, so, and you can see at that point of time, there was a lot of concern about suicide rates within the dorms. Okay, so there was a lot of newspaper reports, including in the BBC, in this covered international press, that, hey, we have mental health issues in the dorms right now because of these clusters. So that is when we really said, well, we're going to keep to our promise no matter what. Let's go back, and we need to capture these. Because say what you want, you can have all these anecdotal evidence, you can have all these press coverage about potential suicides in the dorms or suicide attempts. What gets people to sit up is real numbers on what is really going on in terms of mental health needs. So we brought together a whole bunch of students. Luckily, in Yale and US College, we have very multilingual students. So we brought together all the students from different countries in the world and said, okay, who amongst you would like to do this project? And we said, we need to capture this. And the first thing we needed to do was to try to gain access into the dorms, into the, we talked about the holding sites in the cruise ships. And you can see over here, I wrote tens and tens of emails to people asking, will you let me in? And generally on the phone, when I called people, they would say, this is such an important problem. Let's let you in and you come in. And then I'll follow up with an email and it will be dead cold. We'll get no response. Or here are some sample emails that I received. We can't accommodate the request. Please do not send your students. And I understand it was a very difficult time with a lot of constraints at that point of time. But we're very dogged and we're very persistent. So in the end, we really knocked on every door and we did two kinds of recruitment. We did online recruitment at quarantine facilities like the Expo, at NUS PGP, the cruise boats, and several dorms. And then we also went on site. Especially as the restrictions were lifting, we went on site to the Woodlands Recreation Center. They started to open up for weekend markets. We visited the Health Serve Clinic. We went to a hotel holding site. We went to S11 dorm. Okay, so you can see some of the pictures of our student team going around. Okay, so here are our pictures at S11 team. So you can see, even in that time, bringing a team of students is not trivial. There's still a lot of social distancing requirements. So in the end, through this persistent door knocking, we ended up having a survey of 1,011 migrant workers. Okay, so you can see the breakdown over there. About a small percentage of them were from online recruitment, and then most of them we did face-to-face. The reason why I belabor this a little bit is that we don't actually have much data that is this quantitative, widespread data on migrant workers' mental health. Okay, so even though this study was done some time ago, it remains one of the biggest worldwide on this population. Okay, so just to walk you through a little bit of the complexity of what it takes to run a mental health survey. This was translated into 4 languages. So we had to translate the surveys and then back translate it into English, Chinese, Bengali, and Tamil. What you would find, and this is something I'll pick up later on, is that there are many stock translations of surveys that are out there. Okay? But the stock translations are so highbrow that my university students did not understand them. So let me take, for example, the Bengali survey on mental health that we were looking at. I gave it to my university student and said, let me try it out. Can you do it for me? And they looked at me and said, I don't understand these words, this phrasing is ambiguous. So we said, this is not going to work. And that is why we had to run our own translation and back translation on the fly. And not just that, we also realized that, getting people to read a really long survey was going to be really difficult. And that's why very quickly we discovered that actually what we needed to do was to have our students record the survey and embed it into audio clips on an online template. And so that was self-administered on phones. And if you imagine, we went down and told, because we couldn't give out papers and pens. There was a lot of concerns about COVID-19 at that point of time. We couldn't distribute these forms, so people had to use their own phones. And then we were told by the dorm, actually, the internet is very patchy here. So part of doing this research, which I never imagined I would have to do, was to call up and rent enterprise-grade 4G routers. So this just tells you the sheer complexity of doing a study like that. You can't just think, I'm just going to pull a scale and plug it and run it. That just does not happen. So this tells you the process that we went through, and we did all this in 2 weeks. So very crazy. In the end, the measure that we chose was the 21-item depression, anxiety, stress scale. And we chose this scale because it was widely administered in the community at that point of time, including last week. If you noticed, the Youth Mental Health Survey just came out by IMH. That scale also used the depression, anxiety, stress scale. So as a scale measured in Singapore, it gave very good data that we could compare with in terms of the population and be able to say, is this higher? Do we have higher rates of symptoms or not? Okay, so the depression, anxiety, stress scale is a widely used measure in Singapore and around the world, used in the community to just detect, symptoms of depression. So, for example, whether people agreed that they had nothing to look forward to, anxiety, whether people experience breathing difficulties, and stress, is it difficult for people to relax? So 7 items each. We also asked a bunch of questions relating to demographics, to health concerns, quarantine status, financial stability, exposure to news, and misinformation. Okay, so again, that was taking place in the context of the pandemic. Okay, so with all of that context, I wanted to tell you a little bit of that story of the behind the scenes, because every single time I presented this data, it was during the pandemic, and there was no need to explain all this, how we went through all this process. But now, a couple of years later, I thought that context might be interesting. Okay, so let me walk you through some of the results and talk a little bit about, how is this relevant for the kind of healthcare that we do today. Okay. The first thing that we were very interested in was what are some of the risk factors for poor mental health? So as you saw just now, we didn't just ask the depression, anxiety, stress scores. We also asked participants for lots of different things, demographics, what your health concerns, financial status, all these kind of things about their employment, about their health. And it may not surprise you, that 3 broad categories predicted people's mental health symptoms. The first broad category was pandemic-related adversities. So as Mr. Chua alluded to just now, movement restrictions was a very big predictor of depression and stress. Okay, you can see that in the bars over here. Is there a pointer here? No pointer. But if I walk over there, you can see over in the first graph over there, movement restrictions. The most maximal form of movement restrictions when nobody could go out at all, that was associated with the highest level of depression and stress. And certainly for depression, you could see that movements had this dose-dependent dose response curve, right, with symptoms. Of course, people were a little bit more anxious as well if they actually had a COVID-19 diagnosis, and that was very, very early in the pandemic, so you can understand why there was this concern. But some of the things that are more age-old is actually, how the workers perceive their situation. I mean, all these objective things were going on, But people's perception of the situation also made a very big difference as to how depressed and anxious or stressed they felt. So, for example, you can see over here, in terms of depression, anxiety, and stress, if people had more fears or rated their own health poorer, had more health concerns, they had higher levels on all three. Okay, so that's subjective, independent on whether you had a diagnosis, independent of your health status. If you perceive that you have more health concerns, you had more worries, then you had higher levels of depression, anxiety, and stress. Okay, so you see this in the graph on below as well. Health fears during the pandemic, again, higher levels of depression, anxiety, and stress if you were very afraid. Okay, so there's this subjective perception and fear over here. Also, their financial situation is, again, perception, because we actually ask objective questions on, do you have a bank account, how much did you transact, and all these other questions on actual quantifying of job status, and all those were not predictive of depression, anxiety, and stress. Instead, what predicted depression, anxiety, and stress was participants' perception about their job stability. So their financial concerns, okay, so subjective concerns, and you can see that again panned out. If people were very afraid that their jobs were not stable, that they were not able to send money back, then you can see that depression, anxiety, and stress scores were all higher for that group of participants. And finally, the last modifiable risk factor is exposure to rumors. And that was quite interesting, so we dug into that data a little bit more and had a second research paper on this. So this is about health information in general, which I think transcends the pandemic. On the left, you see the community sample. Okay, so separate out of the migrant worker population, we had also done some research on believing and listening to rumors on COVID-19 in the community. We polled 1,200 people, and you can see that we picked the top 5 rumors, right? That COVID-19 originated from bat soup. You all remember these rumors, that they came from an American lab, that they came from a Chinese lab, or so these were origin stories. But there's also some on prevention. Eating garlic would prevent COVID-19, drinking water would prevent COVID-19. And you can see for the Singapore population that they're much more likely to have heard rumors related to origins, right? So all the conspiracy theories. And you can see generally quite low rates of sharing and believing rumors. That's a slightly different pattern, you can see, of rumor exposure to our migrant worker sample. And you can see over here that while Singaporeans were very concerned about the conspiracy theories, our migrant worker sample were very concerned about the prevention theories, right? That drinking water and eating garlic could help prevent or cure COVID-19, which again, links back to their concerns and perhaps their situation as well. But the other point that I wanted to highlight was that you can see that there are much higher rates of sharing and believing as well. And people in the health community during that time would say, language is a barrier to getting health information in a timely manner, and that's perhaps one of the reasons why as well. So I think this is something to note in general, right? That how we disseminating health information, because what you assume in a community sample is not necessarily going to be the same pattern of beliefs and sharing and exposure to health information as it is in the migrant worker sample. Okay, so I thought I'll put that out there, and just coming back again. So that COVID-19 rumor exposure, participants who had higher exposure to all these rumors, not surprisingly, also fared worse in depression, anxiety, and stress. These are all sets of modifiable risk factors. I mean, other than having a diagnosis or not, the others are modifiable risk factors, and many of them last beyond the pandemic as well, right? Availability to health information, fears of job stability, fears regarding the health, and those are all things that we can address. But the other part of this equation, and something that I've often, presented this and wanted to emphasize, was that despite all these risk factors, we also see a very strong pattern of resilience within the cohort. And that's because, if I were to document and highlight, what percentage of participants had severe or extremely severe rates of depression, anxiety, and stress, you can see over there that's, the box plot. And, what is really remarkable is that, despite all the movement restrictions, the increased risk of COVID-19 in that time, especially the first couple of months of the pandemic, you can see that the rates of mental health symptoms in this population were near identical to the community sample. Okay, and I think, the message that I've always emphasized over here is that really speaks to the resilience of this population, even, amidst the circumstances. At the same time, I reflected a lot about how do you make sense of these findings. On the one hand, yeah, of course, you see, they're always you'll always be able to find, even within a single population, some people with higher risk factors than other people. And then on the other hand, you see that, yeah, overall they're quite resilient, even in the lockdowns. But at the same time, we were seeing all these kind of articles, right? We were seeing all these kind of articles on, suicide attempts in the dorms. And also, not just that, my colleagues in the Institute of Mental Health were telling me, that for example, hospital A&E rates are differing and increased during that time. How do we make sense of all these? I think one possible way of making sense of the findings is to think of what we call the diathesis stress model. Okay? Which is that, the diathesis stress model of mental health says that, when you see a mental health condition, it is a combination of two things. Predisposition, so some people are at higher risk of depression, anxiety, and stress, and the situation itself. Maybe what we are seeing over here is that the number of high-risk people have not differed, right? But for the number of high-risk people, because the numbers certainly do not seem to be higher than the general population, but amongst those who are at high risk, okay, being in the situation of being in lockdowns and the pandemic could have heightened their symptoms, leading to more A&E visits. That's one possibility. The other possibility, of course, is that our data, may not have accurately captured the true rates of depression, anxiety, and stress, severe symptoms for whatever reasons, and I'll talk about that in a second. Okay? But nonetheless, I think from the two research papers that we published, the kind of picture that I want to summarize with is two parts. Okay, one is a picture of resilience that even during the pandemic, the rate of mental health symptoms in the migrant worker community was near identical to the community sample. But at the same time, that we all can do better to addressing some of the social issues. Psychologists call them the social determinants of mental health. Things like job security, things like health status, things like rumors and information. And then I want to kind of say, all right, what are some things that, we move beyond the pandemic and we can take forward in 2024? The first thing to note is that, I mentioned that, we pulled off a 1,000-person survey of migrant workers, and you don't really see many of these. One of the reasons you don't see many of these is that, it really takes a different approach to research. It takes, as you heard from my accounts of having to get Wi-Fi routers, back translate and translate it many times, this sense of flexibility and doggedness in terms of the research. But there's this other part as well, which not many people realize when they take on a mental health research in the community. And that's the community nature and community embeddedness of your research methods. So a few people know this story. But when we were at the dorm at S11, it was 2 weeks before Deepavali. And one of the staff there said, okay, who had been really helpful to us, saying, come into our dorms, we will welcome you, please come and do your research here. We came. And then as we were leaving, I got a text message from the staff saying that in 2 weeks, it's Deepavali. You know our migrant workers, our 8,000 residents still cannot go out, right? Can you provide, you promised that you'll do anything if we needed any help. Can we call you back on that? Can you provide refreshments and snacks and just some festivities for our 8,000 residents in 2 weeks? So what do you think you do as a researcher? Say, no lah, I'm a geeky professor. What am I going to do? Huh? How am I going to get so much stuff? No lah, you do community research. You say yes, okay? So I went back to my students and I said, remember we did this survey in the dome? And this was their request to us. And we promised that we are not fly-by-night researchers. We are there. What are you going to do? So kudos to my students. We ran around the country getting donations. We hired trucks, like the trucks where I had to climb up. I'm so tiny, right? To climb up to get the trucks, go around to all the factories in Singapore asking people for donations. We did it. This is us in exam week. So kudos to the students. This is exam week, okay? And someone had donated to us 800 grams of dried mangoes. And then the dorms told us, 800 grams of dried mangoes, you cannot just distribute like that because it's a pandemic and there's a lot of public health concerns. You need to individually wrap them. So we literally spent 1 week doing that in exam week. And we did it. We brought back, you can see, trucks and truck full of packed mangoes, plus water, plus everything donated by many, many generous sponsors. I tell this story not because I think we're great. I mean, we very much felt inadequate throughout the entire research process. But to say, you know, to people who want to do mental health research in the migrant worker community or any, communities that's not the general public and that, you know, you have to be there in the community, do this kind of research. But the other thing is I wanted to stop and pause and do a bit of postscript and some reflections from 2024. When our study came out, okay, it was like a dream, okay? Because it had taken us from the start of the pandemic until whenever it came out, months and months of sheer hard work. Can you imagine from the start, calling people non-stop saying, please let us in, going by every backdoor channel we could to get into the dorms to do the survey. And it was so difficult. But when the results came out, it was splashed. Some of you might have seen this. It was a 2-pager in the Straits Times. Even the New York Times picked up on it. And that started a national conversation on what we're going to do about these results. One of which was picked up in Parliament, debating about, do we need to remove the movement restriction regulations in the community at that point of time? And I think this story really, I mean, when I started this project, as you remember, it was a promise to Dr. Goh on a live conversation. We never imagined the kind of impact like that. But I think one thing that it made me realize, and all my team members, was that data gives you something to talk about. And why, particularly in migrant worker groups, we really need data. And data is very hard to come by. But you really need data because data gives you a seat at the table. And of course, as we remember, in June 2022, a few months after this incident, the movement restrictions were lifted. So, ongoing challenges in services and research. I think some of the challenges that we face while doing this research remain today. True today, as we heard in Mr. Truss talk just now as well, there are many language and cultural gaps. Okay, the tools that we have for mental health, the treatment manuals, all these things are written in English. 99% of our materials are in English. So for example, this is a manual on on the cognitive behavioral therapy, SATA treatment manual. It's in English. This is a manual for the back depression inventory. It's in English. Many of these things have been translated to varying degrees of success. As I told you, my university students could not understand some of the materials. So I think we do have a language and cultural gaps in our tools. It's also cultural gaps because, as I mentioned, we gave all these questionnaires out, and then I talked anecdotally to my husband who was working on the ground during that time, to many of his colleagues, and some of the things that they were telling me was that people don't say I'm feeling stressed, right? They'll say I have a stomach ache, I have a back pain, and none of that is captured in our tools. So really, how good are our tools in picking this up? That was a problem in 2020, and it remains a problem in 2024. We don't have good enough language-appropriate, cultural-appropriate tools and treatment manuals for mental health services to migrant workers. Of course, we also know that in general for men, and we're talking a lot about men in this study, there are many barriers to help seeking in mental health. This is true all over the world. Okay? And also we know that, it's very complex when mental health is very closely linked to the social situation. How do you tell? How do you go and seek help when much of your anxiety is related to your fears about job security? It's very difficult, right, in that ecosystem. So I was very excited to hear when HealthServe started the mental health and counseling services. But I think even going beyond that, we need to think more creatively about new tools and methods to provide mental health services for migrant workers. And here are just some of the new models for mental health that are going around. One is called the Common Elements Treatment Approach. It's a modular, community-based approach that has been developed for lay providers deliberately for settings where you may not have like 50 psychologists in a small unit speaking your language, for example, right? So, for example, this approach has been used for Burmese refugees in Thailand, for women in Zambia, and just try to think, how do we use the best evidence, translate them into community-based mental health services when we don't have, let's say, that many trained psychologists speaking the correct language, for example, okay? The other thing is to think about, just really creative models. And some of you might have heard of these models of mental health. One is this study from Zimbabwe, how a bench and a team of grandmothers can tackle depression, where they went and set up a bench and trained the grandmothers trusted grandmothers in counseling techniques, and then put them on a bench, and then it was very, very effective in providing mental health services, again, where there was not enough psychiatrists, when there's not enough clinical psychologists. And then here, just a couple of months ago in Australia, a motorbike club helping to address suicide rates in men in rural Australia. So I think just trying to think out of the box. Can we think of creative ways to provide mental health services that are not our, cognitive behavioral therapy written in the English module, tested in the US, for example, right? And I think that's the kind of model that I want to encourage all of you to explore. Very quickly, just want my acknowledgements, very, very long acknowledgements of the many, many people who made this study possible. Okay.
Thank you very much, Professor Jin Liu. The same thing, we're going to have a Q&A session now. Do we have any members here have any questions for Professor? No, seriously, huh?
I'll ask all the hardest questions and send them to Jeffrey.
Okay, maybe they actually asked the questions already, through the QR codes. So once again, a big round of applause. Please remain where you are. At this point in time, I'd like to invite back on stage SATA CommHealth Medical Director, Dr. Cheryl Lather-Glenn, to come on stage to present a token of appreciation to Professor Jin Liu. We have two amazing ladies on stage, ladies and gentlemen. Okay, we're going to capture that special moment. A very big thank you to the two ladies. May we invite you to take your seats. Thank you.